Hello, my name is Christina. I am a learning disability nurse for the hospital. I've come to tell you what a learning disability is, and also just to give you support in how to support somebody with a learning disability. So first of all, we need to establish what a learning disability is. The Department of Health defines somebody with a learning disability who has significantly reduced ability to understand new or complex information or to be able to learn new skills, therefore having a cognitive impairment. They may require support to live independently, therefore they may require 24-hour care support, a few hours care a day supported, a few hours a week. Many of our people will live at home with their families, elderly carers, or live in residential or supported living. We have very few who would live in a nursing home. The learning disability would need to have started before the age of 18, and their IQ would be less than 70. How this would come about is they will be assessed by either a paediatrician, or it gets picked up when they go to school, or parents and carers may think, oh, my child's not developing as quickly as the sibling or so forth. Things may be quite obvious during the milestones. People can get confused with the terminology learning difficulty and learning disability. A learning difficulty is basically people who have problems in reading, writing or numeracy skills. They then have emotional or social difficulties. Perhaps they've had not such a good time in school due to various issues. Children may have ADHD, but it does not necessarily mean that they have a learning disability. Asperger's syndrome also comes into this category. It is not a learning disability. It is of autistic spectrum disorder, however it's the higher end of the spectrum scale. You can have people with autism but don't have a learning disability. However, the people I cover can have a learning disability and autism. So if you are not sure as to how or what this patient presents, please give me a call and I can help where I can. I can do a bit of detective work, for example, liaising with social services or other records and obtaining information from other sources. The causes of a learning disability is, as it says, before birth, during birth or after birth. We do have people who, children who were completely fine as a baby, and then they may have contracted an illness or had a trauma which then would cause them to have a learning disability, such as whooping cough or encephalitis or so forth, or being in a car accident. However, there are issues when a child reaches 16. This is a bit of a grey area, whereby, say for example, they had a car accident on their 15th birthday. We would look at the criteria around the car accident as to whether it's a brain injury or a learning disability. If on their 18th birthday this happens, they would be classified as having a brain injury. So just be mindful as to the history that you're getting with regard to how the learning disability may have occurred postnatal. We are a growing population, as is the learning disability population. We have about 1.5 million people with a learning disability, though this is increasing. Our learning disability population, they're getting older, however they're still dying far too young. On average, a female is dying about 25 years younger than the generic population, and the male about 20 years younger. With any death of a person with a learning disability, a leader review is carried out, just to establish as to what happened before leading up to the death. Could things have been improved? Were there some social issues or health issues that contributed to the early death? And sometimes we need to learn from these, or we think, yeah, we did our best to help this individual. Unfortunately, we don't know about everybody with a learning disability in Croydon, and we may only know about 1 in 5 persons with a learning disability who access our services. And sometimes we have issues whereby a patient comes into hospital and they have had no services at all, and it becomes a crisis management. For example, a person with a learning disability may be living at home with an elderly relative who was told in the past, take your child home and look after them. And of course that's what they would do, and they'd be too scared to let their adult child go. And then it becomes a crisis when they become ill or too old to look after the individual. In Croydon, we know of about 1,400 people with a known diagnosis of a learning disability, but not everybody will access our services. And as I said earlier, a person with a learning disability is 4 times more likely to die before the age of 50. So, we know when we're not well, and we know what to do. We know how we're feeling, we can communicate this. We can tell someone how we're feeling. We can get help from a GP, and we can describe our symptoms. Diagnosis is made, or referral is made, or we're taken to hospital. It sounds pretty easy. However, a person with a learning disability may not be able to do this. They may not understand what's happening to them or how they're feeling, and they may express this by their behaviour. Change of behaviour, perhaps their behaviour becomes more challenging, or perhaps they become more withdrawn. They may not be able to verbally communicate it, but show it in other ways, which to people is exhibiting challenging behaviour, when in fact they're just trying to tell us something. More often than not, we are able to establish the reason behind the behaviour. We very often get referrals for challenging behaviour, and the first thing that we do is we look at their physical health, just to rule out if there's anything underlying which could be contributing towards a challenging presentation. Many of our people will live with carers, paid carers, who don't understand how to communicate or understand the person's needs, and therefore they just assume it's a behaviour. For example, I can give you an example of a young gentleman who was brought in to hospital a while ago. He'd already been to 2 other hospitals prior to coming to Croydon, and therefore when I saw him, he was pretty confused. He had autism, he had a very challenging behaviour according to carers, and he was non-verbal. And his parents were able to tell me what was happening. They were able to tell me he was becoming more withdrawn as time was going on. He wasn't engaging with his favourite activities, he wasn't eating or drinking, and he wasn't really too keen to see his parents, who would visit him every single week. The carers referred him to mental health unit because he needed his mental health reviewed. However, sadly, he had a seizure and went into status epilepsy. From that, he was taken to the Princess Royal Hospital, where his epilepsy was stabilised. And it was there that they discovered he had a rotten tooth. Because of that, he was then sent to King's. He was in intensive care also. He was sent to King's because they were specialists with dental care. And they managed to sort his teeth. And then he was transferred here. So you can imagine he's a bit confused. He's been transferred to 3 different hospitals in a few weeks. He'd lost all his skills. He'd lost his self-help skills. He wasn't able to walk, he wasn't able to feed himself, and he became incontinent. He'd lost all his skills. And therefore we had to build him up again, and it took a number of months. Because the home said he was very challenging, it was thought that he would need a one-to-one support. Actually, he didn't need that at all. I ensured reasonable adjustments were in place when he had a side room, and I suggested that the room could be made into like a bedroom for him, so that he had all his familiar items with him, and all the things that he liked having around him, photographs, toys, cuddlies, and things like that. And over a period of time, he got used to people around him. He began to walk, he began to feed himself, in his own way communicate, and he made friends with the nurses and was actually eating their lunches for them and watching TV. And so he progressed really, really well. And his parents would see that, and they would visit every single day. So this just shows how little training the carers do have with supporting someone with a learning disability without the actual training that they receive. Diagnostic overshadowing is often heard with people with a learning disability. People say, oh, they've been doing it for a few years, tapping their tummy because they're in pain, and then it becomes a habit. And in fact, they're trying to tell you they've got a tummy ache, and then in fact, you find that they've got serious issues and so forth. People will therefore just diagnose the learning disability rather than what's behind the behaviour, therefore diagnostic overshadowing. It'd be good to look at what diagnostic overshadowing means, I'm just giving you a few examples. So as I said earlier, people with a learning disability are 4 times more likely to die before the age of 50. Okay, so just being mindful as to when they come into hospital, what support needs they need when they're being discharged. Can they go back to their destination, depending what they've come in for? Already start discharge planning. Because as I said earlier, many of our people do not live in nursing homes. They live in residential or supported living and have untrained staff. Do they need equipment? Do they need extra package of care support and such? Just be mindful as to the information you're getting and just get your gut feeling as to whether the placement is the right place for them. It might mean they need to change placement, and therefore we need to plan ahead and look at the discharge planning. And I can always help you with that. People with a learning disability are more likely to have a lot of health issues. You get some people who are quite lucky and have few issues. And sadly you get people with a long list as long as your arm, as we see here, who are anything and everything. People with a learning disability are more likely to have epilepsy at some point of their lives, whether it be controlled or poorly controlled. They're more likely to have hearing problems, and it may be due to the fact that they're full of earwax and it's not noted, and therefore it affects their balance, it affects their communication and so forth. I worked with a chap who was having issues with his balance, and his ears were checked, and they were in fact so bound up with wax that he actually had to have a general anaesthetic to have all the wax removed. Once that was removed, he was almost like a new man. He could hear me, and he was trying to communicate more effectively, and his balance improved so much. So we had to make sure that the carer did ensure his ear care was paramount. Visual problems. A lot of our people will not have had an eye test. They find it quite invasive and quite scary to have their eyes looked up and so forth. And they may not be able to tell you as to, they can't read the letters or read the numbers or recognise colour and so forth. So just be mindful of that. And they may show it in different ways, such as rubbing their eyes or bumping into things. They may not even wear glasses when they're offered. Dementia. This is certainly on the increase, certainly with our client group as well, and people with Down syndrome who are now living longer. Back in my heydays, a person with Down syndrome would live to in their 20s or 30s. Now, I'm supporting someone in their 60s and 70s. However, the older they do become, the more likely chance that they'll have dementia or develop dementia. Dental is a big issue for us. Again, many of our clients may not like going to the dentist. I know some of us don't, but we do it. For some of our clients, they don't have the understanding that they need to sit in the chair and they've got all the machinery and looking in the mouth and sit still and so forth. And poor oral care support by their carers. A lot of carers think it's not very important and they won't suffer. But of course, as you know, poor oral care can have detrimental effects upon other health issues. And gastric esophageal disorder, gastric reflux, that occurs a lot, particularly those with postural issues. And we have a lot of those, and then it increases the risk of aspiration pneumonia. And aspiration pneumonia is one of the highest killers of a person with a learning disability. We have people who suffer from constipation, particularly those with autism and high anxiety, and those with mobility issues. And I have had people who have died from being so severely constipated. And I've had people who survived, but just. And if you want to know any more, then please do contact me and I will talk you through this. So, when a person comes into hospital, we need to get to know them. We need to look at our communication, how we come across to that individual, and improve how we speak to them. Some may respond quite well with simple language, others may require support with other sign language such as Makaton, which is the main one we use, or rely on their carers to help communicate their thoughts and feelings, and the same from us. They may require support with pictorial information or objects of reference. It may be manner of speech, how we speak, our tone. Some people like firm approaches, other people like gently approaches, depending how they respond to that. And it might mean that they don't respond to you, but they respond to the next nurse the next day. And you may just have to swap and change to help to formulate a relationship and good communication. And lastly, consider the legal issues. We're all having MCA training all the time. We're having to seek capacity to consent in best interest and reasonable adjustments. Reasonable adjustment is quite simple. It doesn't have to be complicated. Reasonable adjustment can be us adjusting to the person's needs in how we speak and how we come across. Reasonable adjustment can include carers coming into the hospital at different times of the day. We do have strict visiting policy, but we in learning disabilities, and I'm sure in other categories, have made reasonable adjustments. We need to be seen to be making reasonable adjustments to allow the carers to come in and support the individual at any time of day. It also helps you, so you can learn from them and see the other patient too. So when the patient comes in, get to know them, find out more about them, get their history, use a healthcare passport, ask for it. And I'm sorry, you get some really good information in healthcare passports, and you get some with just one-liners. If you do get that, please phone home and just say, could we have a bit more information please, because your passport is pretty poor and it's not telling us very much. I'll be quite honest, and I will do that too. You can write in a healthcare passport, you might find some more information that's really useful for you. Add to it, because the more information that's in place, the more it'll be able to help you and for that person to build a trust in you. The healthcare passport, I'll show you, looks like this. It's their personal property, it belongs to them, it goes everywhere with them in the hospital. It stays with them on the bedside. It does not go in the filing cabinet with the nurse's notes or the doctor's notes, and it's not private. It's not confidential. It's information for everybody. It's information for the nurses, the doctors, for me, for anybody who's supporting that individual. And it's almost the healthcare passport is speaking for that individual. It talks about, it has the traffic light system, whereby it talks about things that are really important that you need to know about me, and things that are important you need to know about me, such as how I eat or drink. Please read these. Please don't assume that the person's incontinent because they've got a learning disability. Please don't assume that the person's bedbound because they've got a learning disability. And this is where I, as an acute liaison nurse, do get a bit cross when it's not read and assumptions are made. Please read the book, and please get the information from the carers. And my likes and dislikes. It might be that they don't like spaghetti bolognese, but they like fish and chips every day. Or it might be they don't like being touched, but of course in hospital that's quite difficult. So we need to sort of establish ways of how we can touch, such as putting blood pressure cuffs or blood tests, and how we can help them go through that anxiety. Involve families, involve carers. They are part of the decision making also, and part of the best interest decisions. Call me. I work Monday to Friday, 9 till 5. I have a mobile and I have an email. And I come around the wards about 4 times a week to check on everybody. I don't have a magic ball, so I won't know who's in. So you need to ring me or email me to let me know who's around. And my contact details will come later. And as I said, plan discharge and admission. Plan ahead. Do they need extra support? Do they need new placement? Do they need equipment? And so forth. Other methods of support would be a communication book. So, for example, somebody who has communication issues may have a booklet that helps them with their communication, and they can show you by pictures and other forms of. They may have a behaviour passport as well, which tells you how to help me when I get anxious. When I do this, I will hit out. When I hear somebody say something, I will hit out. I'll start hitting myself. So you can look through as to how you can help that individual and use that consistently. And it's very, very important to hand each of the communication message to each of your team. Other source of information is easyhealth.org, which is pictorial information when you're trying to explain a procedure to the individual. They may not understand it in speech, but maybe it is to understand better in pictures or actual objects of reference. And in order to back up what I've been saying to you, there's the RCN booklet that describes the meeting the needs of people with a learning disability, particularly around their health needs. Hospital communication book is another useful tool, and each ward should have one of those. I don't carry many around with me, but they are quite useful for those who are able to communicate by pictures and symbols, although a lot of my people do prefer objects of reference. But just be mindful that these are on the wards, and they're quite useful for anyone with a cognitive impairment. So as I said, consider the legal issues. Do they have capacity to consent? If they have capacity to consent, then yes, continue with what you're doing, providing you explain the process and so forth. If they don't have capacity, we need to go into the best interest. But I won't go into this too much detail, as you should have some MCA training anyway. But I can help you through this if you need. Reasonable adjustments. As I said earlier, reasonable adjustments can include allowing carers and visitors to remain with their individual if they are able. Sometimes some carers are really good and will remain with their individual, but they are not obliged to. Please do not expect the carer to remain with their loved one or their individual. Particularly for families, it may be a little bit of a break. However, they may want to come in just to support them with meals because they may find it difficult to eat in a strange environment and so forth. And they may come in just for a few hours just to help that person remain calm, or even to come in when they have a procedure. Sometimes we may need to get extra one-to-one support, and I can support you through that, or I can get to some agreement with the home. So don't assume that the person will stay. Reasonable adjustment can also be appointment times. Perhaps the individual is better in the morning or after lunch. Because waiting is quite difficult for a lot of our clients, so we try and ensure that appointments are at the beginning of the day or just after lunch or the very end of the day where they don't have to wait so long. Reasonable adjustment can mean anything. It's adjusting to that person's needs. And it comes from the Equality Act 2015. Reasonable adjustment also includes me. I can help where I can. Time not taken is time wasted. Can also be resource wasted and can lead to this, which I don't really want. That's why I'm here to support where I can. My contact details are as follows. As I say, I'm 9 till 5, weekends you're on your own, but I do come back to you as soon as I'm able. So finally, as you can probably gather, people with a learning disability are quite complex. We have the few who are quite easy and quite straightforward, but the majority of our people will have underlying or ongoing physical health issues. We may not know the cause of the learning disability. A lot of our clients will have communication issues, verbal, not able to communicate verbally, but to communicate other ways, such as non-verbal, through their mannerisms or through their behaviour, or using signage. Processing of information as well. We need to give them time to process that, or even simplify what we're telling them, and not too much information. There may be health style issues. Those who have a mild learning disability may choose to smoke 100 cigarettes a week or drink 7 pints a day. They may have the capacity to do this, and it depends on their lifestyle. And sexual health as well. Many will not have the input as the generic population about the importance of sexual health. Having the reliance on untrained carers to support them, that can be an issue with somebody with a learning disability and not understanding their needs. The amount of medication. Some will have few medication and some will have umpteen medication to counteract this one, to counteract that one, and so forth, or certain allergies or so forth. And therefore they can lead to late diagnosis, particularly if we can't pick up what they're trying to tell us or what is going on. So this is just a sort of covers a very small area of learning disabilities. As I say, I'm always contactable. If you have any concerns, or you just need to check out something, or you're not sure about something, you want to know how to communicate with this person, anything, I am here to help. I may not get to you straight away, but I can advise on the phone, and I can come to the ward as soon as, and we can discuss together. I'm also happy to give ad hoc training on the wards if needed, and I'm happy to have a little chat with you and so forth. Any worries or any concern, please do not hesitate to contact me. Thank you.